And welcome to the podcast. And without further ado, let's go to the benefit whisperer himself, Ralph Weber. Ralph, how are you, my friend?
I'm very good, Bill. Good to see you again.
That's great. It's great to see you. I am intrigued about today's topic because you are correct. Looking over this research, there were certain assumptions that I had made that you totally blew out of my mind. They weren't true.
No, it's exactly true, but nobody knows these things, Bill. A lot of people don't know these. It happens in the drug market, the PBM market, and it happens in the healthcare market where the pricing, there are huge variabilities. I've talked about them a little bit in past episodes.
You have. You've talked about them in the past. And before we confuse people with what we're talking about now, why don't you tell us what is on the table and what you are going to educate us on, if you will, please?
Okay, sure. Well, Bill, one of the things that I like to talk about is, obviously healthcare, reducing the cost of healthcare. That's the important thing. And when you have a health plan, whether it's with one of the big insurance companies, Blue Cross, United, Cigna, Aetna, et cetera, they have a network, a PPO network, and most of the people just assume that the network has done a very good job negotiating prices with the providers. Okay, I mean, after all, isn't that what insurance is supposed to be for? That's what people assume. When you look at it, and the thing is, if you have a plan that is fully insured as opposed to self-insured, you often can't get look at your data. So that's a problem in itself. Self-insured plans, you own the data. So you always can look at it subject to privacy concerns. I mean, you can't necessarily see who had the claim, but you can see how much of your money was spent paying claims. And often, as I'm going through those with employers, I see these big spreads in pricing, these big ranges. For example, and this is an example I gave before, where I saw 3,100% variance from, now this is not from the low to the high. This is from the average to the high. So for CT scan in the state of Tennessee, both of these happened in the state, and it wasn't just one and the other. The average price was $635 for a CT scan of the abdomen with and without contrast. And the high was $19,800, 3,100% spread.
Rob, how can there be such huge price swing? I think most people think, well, it's 619 here and probably 625 over there and maybe 609 over there.
Right.
But that's not what you're talking about at all. So how can we see such huge price swing? Why do we see them?
The why is a mystery, and it's designed to be shrouded as a mystery. Because not too long ago, employers never even saw these. They just saw averages, okay? So, and people didn't ask questions, but today, people have way more access to information than they did even 15, 20 years ago. So they're starting to ask why, and they're starting to say, well, this doesn't make sense. So one hospital, and I have a very, very good friend named Eric Bricker that is super knowledgeable about this stuff. So, Eric used to negotiate with the providers on behalf of the insurance companies. And what Eric told me is that sometimes they would say, okay, we're going to give a 75% discount on imaging, but only a 25% discount on the surgeries. And then the other hospital that could be literally across the street would do the reverse. 75% discount on surgery and 25% on imaging. So if you knew all of the prices in advance, you might say, well, I'm going to get my MRI done here and then get the surgery done here, but you don't always know it. And of course, it's really hard to change hospitals in the middle of the game.
Yeah. Well, as you know, Ralph, I spent a number of years as a business and finance reporter. So I usually, the old saw every day in the newsroom was follow the money. So my first thought here is like a variation of that, which is follow the incentive. Because I'm wondering now, listening to you, who benefits? Who benefits from this confusion and lack of transparency?
Well, the insurance companies mostly. and or the networks that price them. So in the self-insured world, I think 76% of employers outside of the government plans, Medicare, Medicaid, VA, et cetera, of the privately insured companies in America, about 76% are self-insured. Some of them are self-insured through the big insurance companies. Okay. So the insurance company acts as the TPA or third-party administrator. And what they do is they put pieces together. They charge a base admin fee, and then in addition they charge a network rental fee. They put in stop loss in there. So anyway, there's a bunch of components to the administration, and what they will sometimes do, Bill, okay, is, for example, let's say you're an employer, you're coming up to the end of your plan year, and somebody gets a knee replacement. Okay, so let's say it's December 21st. They're not going to pay the claim that year, okay, but they're notified of the claim. Now, there are several different numbers that are all sort of, a shell game. There's the billed price or charge master. Then there's the allowable charges after the insurance discount. And then there's what's actually paid. So those could be those usually are three very different numbers. So they might charge, for example, $84,000. Okay. Insurance company's never going to pay that. They might pay 64, they might pay 36, of which you pay, of course, your deductible. So when they get a notification that somebody's gone for a knee replacement, sometimes what they do, and this is very nefarious, okay, it's called cross-plan offsetting. They'll actually put a ledger entry in for $84,000 because that's what they were charged. They haven't settled it yet. Might not be settled until next year, okay? But they'll put that ledger entry in. Now, not sometimes, they always pay far less than the $84,000. Sometimes they don't credit the difference, okay? And that's and sometimes the reason, and this is a whole different ball game, cross-plan offsetting. This would take, an hour just to explain that. But sometimes they'll charge it. They'll give a credit to a different employer from employer A to employer B, which is completely illegal.
Wow. Okay. So we're talking about PPO plans today.
Yes.
And usually employers, I think, believe with some reason that they are saving money when they use these PPO plans.
Correct.
It doesn't sound to me like that is the case. It sounds like they're being sold a narrative that doesn't really hold up, based on what I've heard so far.
Yeah, that's absolutely correct, Bill. In the early days of the PPO, and of course the HMO Act passed in, I think it was the 70s. I think it was under President Nixon passed the HMO Act. HMO was about managed care. Before that, hospital charged a price, insurance company paid the price, and that was it. Now, those prices were pretty reasonable prices back then. HMO was about managed care. Okay, we're going to put together the right doctors, the right hospitals, and very good intentions in the beginning. One of the big sort of granddaddies of HMOs is Kaiser on the West Coast. Still very, very much liked by a lot of people that have Kaiser plans. But then the HMOs eventually in the 80s morphed to PPOs, which was a preferred provider organization. That's what it actually stands for.
Okay.
But then they figured that, hey, maybe we can manipulate these prices a little bit. The variance that I told you in a CT scan, like 1,000% between the low and the high is now the norm. It's not the outlier. It's the norm. You'll see that on anywhere between 3 and 10 procedures that happen during the year. And if you're an even larger employer, it could be, much greater than that. So these differences in pricing allow the insurance company to say, hey, listen, somebody had a knee replacement, you were charged $84,000. Okay. And like I said, if it's the end of the plan year, it might not be resolved that plan year. If it's early in the plan year, it might be. So I don't know how they do it, to be honest. I think it's kind of Vegas type tactics where the advantage is always in the house, and in this case, the insurance company.
Yeah. So what role, Ralph, does the insurance company, these third-party administrators, that's what I'm struggling with because, be honest with you, I'm stuck about 4 minutes ago with that price difference between the CT scan.
Yeah.
So what role do the administrators and the insurance carriers play in perpetuating this?
Well, the insurance administrator,
Right.
whether that is an insurance company or a private third-party administrator, their job is to follow the plan document. Okay, so the plan document is an agreement between the plan, which is executed by the employer. It's usually a separate entity from the actual employer.
Okay.
So they set up a plan and it talks about what's the deductible, what's the copay, what's covered, what's not covered, et cetera, et cetera. And then they say, we're using ABC network. And it could be, like I said, one of the big insurance company networks. It could be a private network. Then the network agreement is a separate agreement. Okay. And within that network agreement, that's where they have negotiated different rates with different providers. And they usually redo these negotiations every 3 years or so. Sometimes doctors or hospitals drop out of network and sometimes they drop back in. You might go to a hospital that has just dropped out of network. So now all of a sudden you have an out of network claim. And the insurance companies also make money on that because they charge you to negotiate that out of network claim. So if they're charged $84,000 for an out of network claim and they only pay $54,000, they'll say, hey, we saved you 30 grand and we get 20% of that 30 grand. So that's done a lot too. So the advantage to the PPO networks is having these erroneous high charges, which they never pay, and then they sort of negotiate it down, which often is just what they pay.
I knew this was a complicated topic before. Anybody that has a insurance plan or has health insurance understands, because I've had a couple of surgeries in my life, and I've gotten those bills, and I've looked at, this is what it is. This is what we pay. This is what you pay. And you break all of this stuff down, and it can give, oftentimes it's good you're on painkillers when you're reading it.
Absolutely. Absolutely. And then often, Bill, there are erroneous charges. $100 Kleenexes, too many units of respiratory therapy when you're coming out of anesthesia. So sometimes they charge, number one, outrageous amounts for things, but sometimes they charge for things that actually didn't happen. And sometimes tens of thousands of dollars of drugs, which may or may not have been administered. And sometimes it's an honest mistake. Sometimes they just say, hey, they usually check this off, so let's just go ahead and put it in. And sometimes it's intentional.
Wow, this is fascinating. So how does this pricing inconsistency, Ralph, affect self-funded employers trying to manage their costs? I would imagine it has a pretty dramatic impact.
It sure does, Bill. I mean, if you were a procurement officer for, let's say you work for Starbucks and your job is procuring coffee beans, okay? So you know that there's going to be a variance between Brazil and Ethiopia and Indonesia, et cetera, et cetera. I mean, we all know that, right? That's fine. Mm-hmm. But within one sort of region and one type of coffee, you probably have a mandate. This is the most tolerance that you'll have to purchase that, whether it's coffee beans for Starbucks, steel for General Motors, rubber for Michelin, whatever. They have a procurement sort of a range. And I think most procurement officers usually have a range of just a few percent, unless there's something just very, very strange which happens, in which case they have to adjust their pricing. In the insurance world, if it were 100% at the most, that would be much better than the status quo. Sometimes it's several hundreds of percent, several thousands of percent even.
I'm struggling with this, Ralph, because it's like what you're talking about is if you're the procurement officer for whatever company ABC, pick your company. Right. You have a budget. Mm-hmm. They present you a budget and they say this bill. These are the ranges. This is your budget in terms of and we're going to need this much. So you figure out how to take that budget and get this much stuff.
Right.
It's a pretty simple equation. Really.
It is. It
It
should
may
be
not be
pretty
easy.
simple.
It may not be easy to get. It may be difficult. It may have challenges, but it's usually pretty easy to understand.
Right.
This doesn't even. I don't even know. I'm at a loss for a question when I sit here. I'm more astounded than I am anything else. How could a procurement office, somebody at a company, say, "Hey, we want to provide healthcare insurance," and have the budget be non-existent? Really, is what I'm hearing.
No, you're right, Bill. And the question is, it starts with the acronym is WTF. You know? So instead of being the CFO, you should be the WTF officer.
Yeah.
But Bill, the thing is, benefits are often the second largest line item for a company after payroll.
Right.
Okay. For many, 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 many companies. Okay. That's the second biggest line item. The company has a CFO, but the health plan is a business within the company. The average, and we talked about this on a previous episode, the average spending per employee per year now is $16,500. So if you've got 100 employees, you might be paying $1.65 million a year. And I know a lot of companies that are $10 million companies that have $1 million health plans. So 1/10 of their whole revenue. Some are even higher, some are lower, but a substantial chunk. And most $1 million businesses have a CFO, but most $1 million health plans don't.
Well, what does this mean for employers then, Ralph? What does it mean in terms of like out-of-pocket cost and that kind of thing?
It's what drives inflation, Bill. It's what causes prices to go up every year. And employers pass some of that on to employees. They absorb some. They increase their prices on the goods that they sell. They increase their deductibles. They increase the copays. It just has an inflationary pressure. A good friend of mine who was on a previous episode, I think it was episode number 9, was Adam Russo. Adam Russo is an attorney. He draws up plan documents. Okay. And his company does an amazing job. One of the things that Adam and I spoke about was reference-based pricing. Okay. And that is one of the solutions to this huge variability of cost.
Okay. Before we get to that,
okay,
can you give, you mentioned the CT scan and the price variance there within Tennessee. Do you have another example of a real world case where PPO pricing made things worse instead of better?
Absolutely. Rarely does it make things better. I mean, everybody knows that if you go to any kind of a healthcare provider and you say, I've got a checkbook right here, or cash, or a Visa card, I'm going to pay for this thing right now, you're probably going to get a better price than if they bill the insurance company. I've seen colonoscopies where the average price is $1,212 and the highest $17,341. Same network, same insurance company. Again, that's from the average to the high. I've seen things like colonoscopies where the average paid through insurance companies now is it's higher than it should be. I think it's $4,000 to $6,000. But I've seen colonoscopies paid, like I said, $17,000, $18,000. And if you pay cash, you could get it as low as about $1,000, $1,200.
What can an employer do to get out if they're unhappy? Let's say they're listening to this podcast and they're like, wait a minute.
Yeah.
How do I get out from under this PPO contract? What is there a way to do that, or do they have to wait till the contract expires? Or
it depends. Okay, sometimes they can get out right away. Sometimes they can't. You'd have to check, your specific provisions in your contract. Mm-hmm. But next year, when you're talking about your benefits, plan in advance. Okay, and say, okay, so let's examine the variability if you can. Okay, if you're self-insured, then you can. If you're fully insured and you're in Texas, you can, because Texas has some consumer protection for that allows the employer to see some of the prices paid. But in other states, usually if you're a small group, small employer, you can't see what the costs are. But there's variability within there. Trust me, it's happening. So some of the things you can do is, number one, be self-insured. so that you can see these costs. Number two, choose the PPO network. And some of these PPO networks will allow you to have a direct contract with a hospital, with a surgery center, with a physicians group. And that direct contract, you just negotiate yourself as the employer, or sometimes the TPA will do that for you. And you say, hey guys, listen, we're willing to send all of our patients to your hospital, and we're going to pay you within 7 days of you doing the procedure, for example. We want a fair price in exchange. And what we'll do in order to send you more volume is we'll waive the deductible of our employees. Okay, so it's good for the hospital because they collect the whole amount instead of trying to collect sometimes $7,000 out of pocket from somebody that earns $64,000 a year. Is going to be difficult, okay, because that's a crunch. So the advantage to them, they get the money at the time of service, they don't have to worry about the deductible, and they get more patients because the employer is waiving the deductible. So that's one thing. Direct contracting is great. Mm-hmm. Single case agreements can sometimes be negotiated. Sometimes the PPO networks don't like to let you do that. They want you to pay their negotiated rates, which are often higher. One of the solutions that I alluded to a couple of minutes ago was with Adam Russo, which we spoke about. It's called reference-based pricing.
Yeah, explain that, because that sounds intriguing. And I know for those who missed the earlier episode, give us a quick fill-in on that.
So, Bill, reference-based pricing starts with a reference of some sort. One example of a government plan that has reference-based pricing is CalPERS, which is the California Public Employees Plan. They cap the reimbursement of a knee or hip replacement at, I think it's $30,000 still. It's been $30,000 for a long time. And they say, if you get it done for $60,000, you pay the difference. We're only paying $30,000. That's it. That's our cap. Okay. So that is a form of reference-based pricing that has been very successful. Other states are doing it, okay? A lot of employers are doing it. Now, one of the fairly common references is the Medicare price, okay? So Medicare is one of the largest payers. Medicare and Medicaid combined are probably, they're called CMS, Center for Medicare and Medicaid Services. They're the largest payer of medical service, largest single payer. So they have a procedure code for just about every procedure. And of course, as you know, Medicare is generally for retired people. So there might be some pediatric procedures that they don't have. But for the most part, just about any medical procedure that you could have done, any coverable procedure is going to have a billing code, and it's going to have an allowed amount. Now, there's some variance in Medicare pricing. For example, if you're a teaching hospital, you get paid 40% more, because you have to have students and so on and so forth. Rural versus urban are going to have some variance. A hospital, HOPD means hospital outpatient department. If your outpatient is attached to your hospital, okay, that outpatient can charge 40% more than if it's not attached and owned by the hospital. So there is still some variance, but it's not 1,000%, okay? So reference-based pricing takes the Medicare payable amount and then adds a margin of profit. Could be 20%, 50%, 70%. There's some margin that's added to that.
Yeah.
And so you go for a knee replacement, and if Medicare would charge $10,000 for that procedure, that hospital might get paid $15,000. Now there's a scary side, Bill. The hospital could say, well, wait a second. We charged $30,000. and we only got 15. So they might send you a bill for the difference, which is called a balance bill. Okay. Now, they don't always do it. They do it, as a matter of fact, about 2% of the time. And if you tune into episode number 9, you'll hear Adam Russo talking about that. But reference-based pricing goes best with direct contracts, so you have that protection. You know, if you go to this hospital, you don't have to worry about balance bills. Single case agreements are often negotiated. If you pay at the time of care, you're going to sort of negate those risks. But at the end of the day, there is the odd time that there's going to be a balance bill. What you need in your plan is some sort of a backup plan to deal with those bills. Now, one thing, Bill, that you know is when you, as an ordinary layman, get a balance bill, whether it's for $200 or $20,000, you just panic and you say, wow, this is crazy. How am I going to deal with this? Okay. And you call and you say, why, please, you start crying on the phone, but you're dealing with somebody that's pushing buttons that doesn't want to talk to you.
Right.
Once a lawyer calls and says, hey, listen, we're representing Bill Tucker. Stop calling him. You're dealing with us now. And as a matter of fact, we've looked up your charges for this procedure, and we happen to know that you charge so much to Blue Cross, so much to United, so much to Aetna, so much to Medicare. And what you're asking for is 10 times that, which is not reasonable. So let's talk about something reasonable. Once they're talking to a lawyer that knows what they're doing, then that often goes away. Or they negotiate maybe a little bit higher than that 150%, maybe that, it might be 16,000 or something like that. So having a lawyer to protect the plan and or the employees is a very good thing to do if you have reference-based pricing.
So the old saw, know what you don't know.
Yeah, exactly.
It's
Absolutely.
really important here, as a matter of
It's
fact.
super important, Bill.
Yeah, it's amazing. So what should an employer ask when they're evaluating the network contracts or exploring alternatives?
Well, I'll tell you about one client that I have. They have about 400 people. Let me see. They've got about 400 people on the plan. They were with a big insurance company, okay? And they've declined in their number of people, but the matrix of measurement that I used is the per employee per year cost, okay? It was about $13,000 per employee per year in 2020. 2021, they were going to get a big increase, and it was going to almost $15,000.
Wow.
We took over the plan in 2021. We brought their costs to just over 12,000. I think it was about 13,000 something. In 2023, we brought their plan costs down to just over 11,000, and in 2024, $10,099. So 3 years of a decline.
Wow.
While healthcare inflation was going up. The first year we had them they paid 20% less than the average employer pays. The second year they paid 31% less, and the third year they paid 38.8% less than the average.
Good work, Ralph.
Oh, thank you. It was hard work, though. It was hard work, Bill, because these plans have a lot more moving parts. So it is more labor intensive, and it's learning a new game. It's learning to, and Bill, as you know, I grew up in Thailand, so I learned to bargain for things. You don't pay full price for anything. Right. The price is suggested, and you suggest what you'd like to pay. It goes back and forth. Most people that have grown up in Asia, Africa, South America, Middle East are accustomed to this. Even large parts of Europe. It doesn't happen much in the U.S. Where people are bargaining. Sometimes when people come here from other cultures and they pick up something in a store and it's on the floor and it's got a dent, they'll go to the cash register. Hey, can I get 20% off? And they usually do it. Like even that is a good example. So having that ability is a huge plus, and that's what most plans don't have that have PPOs.
All right. So as we wrap this up, Ralph, give us a takeaway. What is it?
Okay, so the takeaway is PPOs do not guarantee savings. They often, what they do, Bill, is they mask the costs behind complex contracts and random pricing. And if you're tired of playing that PPO shell game, it's time to start asking better questions. And the first question, I actually looked at a plan document for a car dealership in Nashville a few years back. And that plan document said, you, the employer, have no ability to ask your employees how much they paid for a procedure, or the providers how much they billed or how much they were paid. We will pay your money, and if you want to know how we spent your money, you can ask us, not them. So the contract is hugely important.
Wow. So you and I, in theory, could have been working for that car dealership, and you and I could have paid very different prices for the same procedure that we had done.
Absolutely.
Wow.
Yeah, absolutely.
You know, Ralph, every time we get together and we put together one of these podcasts, it strikes me that it's like if I'm a benefits coordinator, if I'm at a company and I'm looking at my healthcare costs, I probably ought to be having a conversation with you.
Yes, absolutely.
What is the best way for those folks to reach out to you and touch base with you to see if maybe you could do something for them in terms of helping them save costs?
Well, first of all, they should listen to some of our other episodes at thebenefitwhisperer.com. We have a lot of really good insight on programs like this. They can reach out to us by phone, 832-924-3330. You can email me, ralph@thebenefitwhisperer.com.
That's great. And for those of you who may be listening to this podcast who are not a subscriber, do that. That's easy. All you have to do is hit the follow button. That way, when Ralph drops new episodes of The Benefit Whisperer, you will be notified. You can give it a listen, and you can learn even more of what you don't know already and find perhaps new ways to move forward, saving yourself a little bit of money. That would be great.
Yes, absolutely.
If you like the podcast, I would also ask you to share it with people. Let people know. It is a really interesting podcast about a very complex subject, and the more people that can hear it, the better educated people are. Really, I believe the better off we all are as a result. So,
absolutely agreed.
So thank you for doing that, and also thank you for taking the time to listen. We really appreciate you dropping in and taking part and listening to this conversation today. And remember, subscribe, and we'll catch you next time.
Thank you for listening to the Benefit Whisperer podcast. Click the follow button to be notified when new episodes become available. Looking to reach out? Visit our website at www.thebenefitwhisperer.com or give us a call at 832-924-3330. And don't forget to click the follow button to be notified when new episodes become available. The information covered and posted represents the views and opinions of the guest and does not necessarily represent the views or opinions of the Benefit Whisperer. The content has been made available for informational and educational purposes only. The content is not intended to be used as a substitute for professional investing advice. Always seek the advice of your financial advisor or other qualified financial service provider with any questions you may have regarding your investment planning.